universities and the real world data. Can we have a just quick question that from a primary care perspective, since you represent the primary care diabetes Europe, so which data one should look primarily for in a primary care perspective? From a primary care physician point of view, managing diabetes, what is the importance of a real world data?
So ideally, we will of course prefer to use randomized control trials, but as you know, a lot of our patients in primary care do not look like the patients that are recruited in randomized control trials. We are very aged population, all of them, most of them multimorbid, and so using the data from randomized control trials in our populations usually do not lead to the sort of benefit that we see in the trials. So if you have data from real world, we can actually combine that with the evidence from the randomized controlled trials to make important clinical decisions for our patients.
Thank you, Dr. Samble. And now I would like to introduce our next speaker, Dr. Kamlesh from United Kingdom. Dr. Kamlesh is a very well-renowned figure in the world of diabetes, and he is a professor of primary care diabetes and vascular medicine at the University of Leicester, UK. And his research work has made an impactful contribution to various national as well as international guidelines. And he has published over more than 500 articles. And he's currently the co-director of the Diabetes MSc at Leicester University. And he has several national as well as international awards to his name. I will request Dr. Kamlesh Khunti sir to please come and share his screen and deliver his talk.
Hi, everyone. Thank you very much again for this kind invitation. I'm trying to share my screen at the moment, but it says while others are participating, I'm not able to share. So someone needs to disable it, please, from your end.
You have to stop sharing your...
Dhruvi, can you disable the slides so Kamlesh can share his slides?
Dhruvi? Dr. Dhruvi?
Dhruvi, you need to, stop screen so that Kamlesh can share his slides. Thanks. Thank you.
Now,
Kamlesh,
sir, you can share.
Sir. Thanks.
Okay, can you see my screen now? Can you see my screen?
Kamlesh, your screen is visible. Your screen is visible, Kamlesh.
Excellent, great. Thank you very much. Shashank, Pratap, Bansi, everyone, thank you so much again for this kind invitation. Can I just, first of all, congratulate on an amazing virtual conference. It's really difficult to run them, but you've executed this so well done. So my presentation is regarding turning the frown upside down for GLP-1 receptor agonists, revolutionizing diabetes management. These are my disclosures. Just a quick word about Diabetes Center. Sam obviously is a key part of our team. We have about 160 people. As you all know, I've used this slide before when I come to India, and it's a shame I can't be there in person. But we're about 100 miles north of London. We have about 160 people in the team, and Leicester's unique because 40% of Leicester is Gujarati, and we probably have the best Gujarati food outside of India and the best Navratri celebrations as well. So first of all, just quickly on the epidemiology of type 2 diabetes and cardiovascular disease. We know type 2 diabetes is associated with multiple comorbidities. We don't talk about one disease now. Multimorbidity is a word that's going to be used more and more often over time. We know 97% of patients with type 2 diabetes have at least one comorbid conditions, and about 88% have two comorbid conditions. And this tends to increase with age, with a six-fold increase in co-prevalence of cardiovascular disease and chronic kidney disease from comparing the youngest to the eldest. And it's much higher in men than women as well. And it's associated with worse outcomes, worse quality of life as well. In terms of cardiovascular comorbidities, we know that they are common, and about 75% of people will die of cardiovascular disease. But this is looking at a systematic review of the common cardiovascular diseases that we see in people with diabetes. As you can see here, this is a percentage rate. And overall, about 32% of people with diabetes will have some form of cardiovascular disease. And we know, as I mentioned, it is the major cause of mortality. In terms of cardiovascular disease, within people with diabetes, it occurs about 10 to 15 years earlier in those with diabetes compared to those without. And as I've already said, 2/3 to 75% of people will die of cardiovascular disease. And type 2 diabetes doubles the risk of cardiovascular disease compared to those without. And this is after adjusting for everything. So why is it very important to think about cardiovascular disease? Well, as I mentioned, it's the most common non-communicable disease globally. 80% of cardiovascular burden occurs in low middle income countries, and many of these risk factors are associated with cardiovascular disease. And these are elevated blood glucose, diet, obesity, low levels of physical activity, abnormal lipid levels, blood pressure, positive family history, and smoking. And these are collective risk factors we really need to think about and manage these to reduce the risk of long-term cardiovascular outcomes in people with diabetes. What about South Asians and diabetes? As you all know, in Leicester, we have a huge interest in this area, having published probably more papers on South Asian and diabetes outside of India. But we know 1 in 5 people globally are of South Asian origin. And as you can see, they are have migrated to all sorts. And we always have a joke, you will find a Gujarati anywhere in the world. But cardiovascular risk factors in South Asians are increased even more than the global population with type 2 diabetes I mentioned. These are all these risk factors are increased much more greatly in South Asians. And they have a higher cholesterol, low density lipoprotein cholesterol, triglycerides are elevated, there are low HDA levels. And we also know the prevalence of hypertension is much higher. And this puts South Asians with diabetes at a much, much greater risk. And we've seen this at the moment, it's very topical at the moment with COVID. And I know there's been a number of presentations on COVID, but South Asians in the UK, for the first time, we showed that they're a much higher risk, the Black minority ethnic health populations, and that hadn't been shown anywhere globally before. In terms of South Asians, we know they have an increased insulin sensitivity compared to other groups, reduced sensitivity compared to other groups. And this may be one of the reasons for the increased COVID. We know South Asians have anything from 2 to 4 times increased risk compared to indigenous other populations. We used to say diabetes occurs 5 to 10 years earlier, but we showed data last year that it occurs 12 years earlier now in South Asians in the UK compared to white populations. And a high proportion of people will have the definitions of a metabolic syndrome. So overall, South Asians are more likely to have type 2 diabetes than white population. They have much greater progression we haven't talked about. They have it at a younger age, usually about 12 years earlier, and they have a lot more complications as well. And one of the potential driving factors behind this may be obesity, especially visceral adiposity, which is more prevalent in South Asians and is directly linked to increased inflammatory cytokines and pro-inflammatory markers. And as you know, again, the cytokine syndrome that occurs in COVID may be associated with the greater risk in the Black minority ethnic health populations. We've also seen that they have higher CRP, chronic low-grade inflammation, even after adjusting for everything. And there may be suggestion that there is rapid fat gain in lean individuals in South Asians. So again, this is a contributing factor that's putting people at increased metabolic risk, cardiovascular outcomes, and mortality. So we've gone through all this. They have higher disparities. They have poorer health outcomes, 50% more likely to die of coronary heart disease than Europeans, and highest loss potentially productive years, because as I mentioned, on average, South Asians get the diabetes 12 years younger than white populations. And sadly, the projections are that over the next 10 years, South Asians will account for greater than 20% of cardiovascular deaths worldwide. Even the Indian data show that coronary heart disease rates have doubled in the last 20 years, with up to 25% of high myocardial infarctions occurring those aged less than 40 years of age, those who are most likely to give to economy. There are multifactorial challenges if we take these in turn: early onset, so living with the disease for longer; poor beta cell function; late diagnoses, so managing patients aggressively, and there will be a need to see these patients more rapidly and regularly because of poor beta cell function and failure for the therapies. Need, developed diabetes at a lower BMI, so how do we manage this? They have greater complications. And if we look at the data, this is from data from India showing that about 3/4 of people with type 2 diabetes have diabetes that's not controlled with an HbA1c of greater than 7%. And I know Shashank and Bansi and the team have shown this as well. Let's go to guideline recommendations. Well, you all know this. Melanie Davis and I work together. We're the co-directors at our center, and she and John Buse chaired the ADA ESD consensus report. And as we look at this, we now have great data, evidence-based data, that we need to consider the risk of atherosclerotic cardiovascular disease, heart failure, or CKD on the left-hand side here. About 25% of people will be in this category. And then we need to think about risks such as reducing hypoglycemia risk, weight loss risk, and the cost being a major issue. If we go to the updated ADA ESD consensus report, now just looking at those who have either established or risk factors for atherosclerotic cardiovascular disease, chronic kidney disease, and heart failure. This is the new algorithm, as you see, starting with a GLP-1 receptor agonist or an SGLT2 inhibitor if we think atherosclerotic cardiovascular disease predominates. If heart failure or CKD predominates, then one would initiate with SGLT2 inhibitors. And if people are above target, then going to GLP-1 receptor agonist. And this is the new updated version: established disease or indicators of atherosclerotic cardiovascular disease. And this includes age, left ventricular hypertrophy, or coronary carotid disease, lower extremity artery stenosis of greater than 50%. And here CKD categories and urine albumin creatinine ratio categories have now been added as well. As you know, global guidelines have changed as well. ACC recommending GLP-1 receptor agonists for atherosclerotic cardiovascular disease. ESC came up with some controversial recommendations. The ADA ESD we mentioned, the ADA are also recommending SGLT2 and GLP-1 receptor agonists, and also ACE as well now. The key challenges are managing this progressive disease. As you know, it's easy to manage blood pressure and lipids because we start the therapies and usually there isn't much escalation to do. But as we've said, in South Asians, there is much greater progression that we need to be keeping on top of these patients on a regular and managing from monotherapy all the way to injectable therapy in a more rapid manner to make sure that we get these people under control. We also know that late diagnosis is there in the South Asian scenario, and inefficient treatments lead to poor prognosis in these people. So management is quite complex. As you know, this is a triad of the patient in the middle, the healthcare professional, and the healthcare system, which is so variable, as we know, in South Asia. But there's a lot to consider. These are just some of the things: glycemic control, as I say, seeing these patients regularly, organization of care with other healthcare professionals helping out, the comorbidities, intensification happening at the right time, but also balancing that with the hypoglycemia risk. And there's many other things that one needs to consider. So management is quite complex. In terms of looking at therapies, we know globally there has been not a good uptake of therapies. And the term therapeutic inertia, which we initiated, is very, very present now as it was 10 years ago. If we look at the therapies, this is the exenatide approval that happened in 2005. If we go through liraglutide, exenatide, ER, and all the other therapies, the uptake is not huge. This is the uptake by cardiologists. Suddenly we see especially SGLT2 inhibitors being uptaken there, and endocrinology and metabolism, but uptake in primary care is still not as high. And these are the therapies, you know, biconize have increased between 2006 2013. We've got other data showing exactly the same pattern. But when we look at other therapies, such as GLP-1 receptor agonists, the uptake in 2013 was 5%. If we look at it now, it's about 18% at present. Sorry, 8% to 10% at present, and this is globally. So evidence-based therapies, even SGLT2 inhibitors, haven't really penetrated in terms of management of people with type 2 diabetes. But when we look at that algorithm on the right-hand side, the blue corner of the ADA-EST consensus report, there is this thing: we need to avoid inertia, and we need to manage these patients on a regular basis. So the key challenges: inadequate glycemic control, overweight and obesity, and cardiovascular burden. These are more prevalent in South Asians than other populations. And there are many others that we haven't talked about, but these are not in isolation, and we have to look at all these challenges together and have simple regimes to improve adherence for these patients. In terms of therapeutic options, we have a number of expectations, and we shouldn't just have a glucocentric approach. We need to look at the pathophysiology and try and preserve beta cell function. We need to think about comorbidities. We need to look at the therapies that have proven efficacy for cardiovascular outcomes. We need to reduce HbA1c, postprandial glucose, and fasting plasma glucose, reduce risk of hypoglycemia, and meaningful weight reduction. So this is a vascular glucocentric approach that we really need to manage this metabolic or cardiometabolic scenario that people have. And these are the therapies. I'm not going to go into details about these therapies. These are the newer therapies: DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists. But we know that GLP-1 receptor agonists are a conductor of diabetes orchestra, lowering blood glucose, lowering body weight, and the cardiovascular benefits that we've seen from cardiovascular outcome trials. The main effects of long-acting GLP-1 receptor agonists are regarding glucose lowering, increase in insulin, improve beta cell function, reduce glucagon and gastric emptying. We know there's weight-lowering effect with increased satiation and energy intake, and cardioprotection. I mentioned about inflammation, postprandial lipids, improvement in blood pressure, and increasing heart rate. And there is now some data about improving renal protection as well. Looking at the therapies that we have very good therapies, but they're not being penetrated, all of them, as I mentioned in the earlier slide. But if you look at the key aspects: efficacy, hypoglycemia risk, weight effect, and cardiovascular benefits, we have a couple of therapies that are excellent at the moment: SGLT2 inhibitors and GLP receptor agonists, DPP-4 inhibitors being used more, being very safe, with a lower hypoglycemia risk, but intermediate reduction in HbA1c. But when we look at GLP-1 agonists, we get a high efficacy, low risk of hypoglycemia, weight reduction, and cardiovascular benefits. And when we look at the GLP-1 receptor agonists in a bit more detail, there is heterogeneity. So if we look at the short-acting ones, lexenatide, they did not show cardiovascular benefits. But when we look at the other therapies, the longer-acting, we see significant improvements in outcomes for these therapies. So the characteristics of GLP receptor agonists are nicely portrayed here. The efficacy is good, weight reduction is good, hypoglycemia risk is low. They are costly, yes, but the cardiovascular benefit are markedly improved. Heart failure improvements, there's no data for improvement in heart failure, but improvements in renal function. And these are the cardiovascular outcomes trials, as you know, that have been done. And we see LEADER with liraglutide and Pioneer 6 with oral semaglutide, all of them showing MACE benefits, cardiovascular risk reduction, and all-cause mortality. As you know, Pioneer 6 was a pre-approval phase 3A trial, again, amazing results. These are all positive effects, and these being neutral effects. I must add that SUSTAIN in terms of subcutaneous semaglutide, oral semaglutide, and albiglutide are not available currently in India. So in summary, we can look at a strategy to reinforce the value of our therapies, in particular certain therapies such as GLP-1 receptor agonists, because these are the barriers: poor efficacy, fear of weight gain, fear of hypoglycemia, and poor adherence. But the advantages of GLP-1 receptor agonists are they give us the HbA1c reduction, they give us the weight loss, the risk of hypoglycemia, and cardiovascular efficacy. But there is an issue with GLP-1 receptor agonists, just like others. And this is the first study that Sam and I were involved with two colleagues from Leicester that have now a urine assay for metabolites, a first objective measure of adherence. And as you can see, adherence for GLP-1 receptor agonists is low. About 70% are adherent to GLP-1 receptor agonists. And adherence is a key issue for any therapy we give, because not only will it give a poor risk factor control, but we know adherence is also associated with worse outcomes. So this is a systematic review. Again, Sam and I led on this, showing from 8 observational studies, poor adherence is common, 37%. And if there is good adherence, we have a 30% risk of hospitalization. If you have good adherence, there is a 10% risk of mortality. So we need to start changing and thinking about a whole person aspect. We need to improve glycemic control. We need to improve adherence and therapeutic inertia. We need early treatments. We haven't gone into that, but early intensification leads to better longer-term outcome. And there are now signals showing that they may also lead to better cardiovascular outcomes. GLP-1 receptor agonists have an established efficacy and safety profile, but we now await the exciting prospect of having oral GLP-1 receptor agonists for the future. Thank you very much for listening.
Thank you, sir. You have given us a very wonderful account of GLP-1 therapy and their place in the management of diabetes. Sir, I would like to ask one thing before we move on to our next speaker, that the previous speaker, Dr. Samuel, has also shown that there is a efficacy gap which exists in between the real world data as well as the RCTs. And we also see that in clinical practice, we are not actually able to translate the full benefit of our drugs to our patients. At the same time, there is a therapeutic inertia as well. So in India, we have that financial limitation, but in UK, where NHS supports all these newer GLP-1 analogs and all, what is the acceptance there, and what is the outcome there?
So if you look at the UK data with globally all the data, UK performs as one of the best, like many of the European countries. US spends a huge amount of funding, as you know, but they don't get the same level of improvements. But we're still not there yet. Even with the UK data, when you look at European data, we don't seem to getting to target for these patients. And the factors are not just related to healthcare professionals, there's also related to patients and the health systems as well. As I showed you, adherence is a major issue. Even when we've got a healthcare system where we're giving free medications, if patients are not adherent, that drug is not going to work.
Thank you, sir. And Amit is also back from Lucknow. And I will request Amit to announce the poll question and introduce our next speaker.
Thank you, Amit. That's the beauty of virtual technology. I'm back from Lucknow just in a couple of minutes. Right. So the poll question for this afternoon is, what is the main obstacle to the use of GLP-1 receptor agonist in your practice? Is it cost, side effects, lack of availability, and lack of knowledge and experience? So that is the poll question for you.